So what we usually do in these sessions is there is a presenter, and that's me today, and there is one discussant that will be Joseph for today. And so what we normally do is discuss. So the presenter presents a case that is that is unknown to the discussant, and we present it. We present it in terms of aliquots, um, which are bits of information. So, for example, we just start with a chief complaint, and then the discussant will discuss or will teach us how we approaches that case, and that's how we progress until we come to the conclusion of the case, which is the diagnosis. And our main aim really is not for the discussant to get the diagnosis right, but our intention is for us to learn from him on how he approaches different clinical scenarios, which are a mystery to him. So that's how we conduct these sessions. And so most of the times we actually discuss real cases that we see in our setting. And we have a couple of those. Joseph has some, and I do have some. But for today, since we didn't prepare cases from our setting, we have another resource which is very rich. We introduced that one previously. It's called the Human DX app. So Human DX is a project. We are not even sure who started it, but I think it's a very old resource where they have a collection of cases, and everyone here can actually utilize that in order to practice clinical diagnosis every day. So you can just go on the App Store, on Google Play Store, and download the app, and you can start solving different cases, and they present it in the same manner that we are doing here in terms of aliquot. So today, I I I prompted the system to select a case for me, and I tried to solve that case, and I found it interesting, and that is the case I'll be presenting to Joseph today. So Joseph, are you ready?
I'm more than ready.
Okay, so we'll start. So our case today is we have a 29 years old male with chest pain.
Okay, thank you very much. So, um, there are very common chief complaints that happen in hospitals, either inpatient, emergency, or clinics, that we are we are forced to have an approach at our fingertips, because you will see them very often, or even if not very often, they will have dangerous differential diagnosis that you should pick quickly before they end up into some bad outcomes. So chest pain is one of them. And forgetting first about the age of these patients, and focusing on the chest pain itself. So chest pain is broad. There are so many causes of chest pain, but of importance is to determine the non-miss differential diagnosis that can present as chest pain. That if they get missed, maybe patient might die. So you have to pick them. And for me, I have a mnemonic that I learned from other resources, which is to think of 8 diagnoses that you shouldn't miss when patients present with chest pain. And these include 4 diagnoses from the heart, 2 diagnoses from the pulmonary system, and 2 diagnoses from the GI. The 4 diagnoses from the heart, if I can remember well, include ACS, that we all know, the acute coronary syndrome. Another will be aortic dissection. Another one will be Takotsubo cardiomyopathy, and the last will be cardiac tamponade. So yes, two A's and two T's. Moving to the pulmonary system, you shouldn't miss two things: pulmonary embolism and pneumothorax. While in the GI, you shouldn't miss esophageal rupture and esophageal impaction. Why? Because once one has an esophageal rupture or they have an esophageal impaction, which will end up into esophageal rupture, they will have a very bad complication called mediastinitis, which will eventually kill them. Because once they're infected, the mediastinitis is very difficult to treat. So, in real life, when someone comes into your hospital, they have chest pain, we only do like three things. So, you order an EKG, troponin, and a chest x ray. You catch most of the things here. And also you proceed. So, coming back and looking at the age of this patient, this is a 29-year-old guy. So, if in this case, there will be like confidence that we don't have some lethal diagnosis, then we'll move on and realize what is happening in other dimension diagnosis. And in the chest, there are a lot of structures that can be painful. I'll tell you, in my 2 years as a physician, I've seen chest pain, and the diagnosis at the end was just a zoster. It was just a zoster, and patient wouldn't tell me of a rash, but at the end of the day, it was there. They said they have chest pain. Uh, so that's the skin. So you have the skin, you have the subcutaneous tissue, you have the bones, you have the muscles, you you have the pleura, you have the lungs themselves, you have the costochondral junction. TSS syndrome is one diagnosis. So a lot of things, but that's how I'll be approaching it. And it's unusual for patient who is 29 years old to present with chest pain. But the literature from the emergency medicine says that if you have 100 patients presenting with chest pain, most of them will be discharged without a benign diagnosis. Most that I've seen with chest pain is chest pain of musculoskeletal chest pain of non-specific origin. So I would want to hear what's going on with this lad, and if young people present with a serious chest pain, the diagnosis at the end is very serious. That's that I know. So here in the HPI and the physical exam, and try to figure out what is happening. Next.
Thank you, Joseph. So we move on to the HPA, which is very short. So this is the first early quote. So the patient presented to the emergency room with chest pain for 2 days. The onset was 2 days ago, and he describes sharp anterior pain without radiation. There are no exacerbating or relieving factors, and associated symptoms included tachycardia, dyspnea, and an episode of syncope the day prior to presentation. That's the end of Aliquot 1.
Yeah. Yeah. So of importance there is an acute chest pain, which is typical that you at the end of the day we have to have a diagnosis that should explain this. Most likely, it's ending up with the lethal thing: acute chest pain with other associated factors. Of importance that I'm hearing there is tachycardia, syncope, and SOB. So tachycardia, if you hear it, so ideally when you have tachycardia, at the end of the day you have this someone on EKG to see this tachycardia, is it sinus or not. Sinus, there is no problem with them, but if it's non-sinus, we'll go into that direction. But I believe at the end of the day, this turned out to be sinus tachycardia, which is mostly in a patient with chest pain. It will be because of the pain itself, for example. But again, it can be from, it's chest pain, it's so scary, someone is scared, they have tachycardia. But having SOB and syncope This is very, very important, and it should be explained. So my approach to syncope, I mean to SOB, first of all, that difficulty in breathing. If you have 100% of 100 patients with SOB, at the end of the day, 90% of them, you'll have the source of that SOB coming from either the heart or the lungs. The rest will come from elsewhere. For example, the three A's: acidosis, anemia, anxiety, or someone is very fat, they have obesity, hyperventilation syndrome, for example. But mostly, if you see someone who is difficulty breathing, heart, lung, most patients will end up in here. And if you go into the heart, there are so many structures that can end up as a SOB. From the pericardium itself, it can be inflamed and cause tamponade physiology. Someone end up with a difficult breathing. To the muscle, the muscles themselves, that they can be problematic. Maybe they have dilated cardiomyopathy, or the electricity, they have arrhythmia. You go inside, you find the valves. There can be valvular heart disease that cause SOB. The same applied if you go to the lungs. There are a lot of structures in the lung that can present with SOB, from the connections. I mean the airways, to the lung parenchyma, to the alveoli, to the vessels inside of the lungs. And so if I combine all of these things: chest pain of acute onset, SOB, and they're telling me they have syncope. At the end of the day, if someone prompts me with such an information in a young patients like this, I also we're discussing here, but I would have at the end, one must rule out PE by performing CTPA at the end. Yeah. So let's hear more story, but yeah, these are very important qualifiers of the chest pain of these patients.
Okay, thank you, Joseph. So we move on. Secondary quote. So on the review of systems, this patient reported intermittent fever, chills, uh, sweats, weakness, loss of appetite, and weight loss over 3 months. Head and neck, uh, he had swollen cervical lymph nodes for 3 months. ENT denies sore throat or ulcers. GI, he reports mild intermittent diarrhea. And in the genitourinary, denies urinary symptoms or genital lesions. That's aliquot 2.
Okay. So yeah, this is a nice case. So as the case is unfolding, we are also learning that it is not. We are seeing today as an acute, but you hear this story that we are given here. It turns out no, the acuteness is what we are seeing today, but this guy was sick some months ago, like you say, 2 months, I think. So they have a chronic illness, which we are seeing today. As one day I discussed, I say, if you're seeing a pen is falling from the table, it means it started rolling some seconds before. So it's like this patient. So the story we are hearing now qualifies the chest pain in completely different directions. It can turn out to be those among those 8 diagnoses or not, but now I have to be broadened. So let's dwell on one thing. So this patient also have fever, chills, and weight loss. This means this patient is inflamed, chronically inflamed, and at the end of the day, today they are presenting with chest pain. So if they are inflamed, you just think of IMED. What is inflaming them? IMED, that is IMADE. Do they have an infection? And an infection in a patient with fever should be written in a capital letter and bolded. Why? Because you shouldn't be fooled. Patient with fever, they should have an infection unless proven otherwise. And unless proven otherwise, it means you rule out all possible causes of infections, and then you can proceed to the rest of the mnemonic, the MADE, like malignancy or autoimmunity or endocrine causes like thyrotoxicosis or drugs. We had a case here of a dress. This woman presented with a fever. So yeah, and by doing that, I'll concentrate and think maybe does this patient infected in any way? And if someone they have a fever and they're infected, the next the thing to do is to localize if they're infected. Where is the infection coming from? Where are the portals of entry of infection? So, most common causes include a GU, genitourinary infections. You're talking about a UTI, for example. Complicated UTI can cause fever. Simple UTI never. Is it the GI? This patient are told they have diarrhea. So maybe it's the GI infection that is presenting with the fever. But that GI infection of chronic diarrhea with a fever have to be in a immunocompromised patient probably. And again, what is the other one? Respiratory system. Do they have a chronic respiratory infection that we are seeing its complication today? And again, for a 29-year-old, I don't know where the case came from, but in this region, you think of TB, for example. TB can cause all these things. But otherwise, other infections of the chest that can cause a chronic disease like this will be in an immunocompromised patient. But this patient were not told of any respiratory symptoms. Another source that can come that the fever, the infection can enter the body is the skin and soft tissue, but we are also not told. So what we are told in this patient is that only diarrhea, which is the GI, maybe they have a GI infection, but again we are told they have cervical lymph nodes. So this is what we are seeing, like cervical lymph nodes. This is what you are seeing, but there are other lymph nodes that you are not seeing, meaning inside the body, which you have to have an imaging at the end. So what does this translate? If you see the lymph nodes, maybe they are reactive to a certain infection, or they are just um, they are just growing up without thinking it, meaning they have a cancer. So I wouldn't hesitate to think of a lymphoma. um, that I'm seeing the lymph nodes here. Maybe there are other lymph nodes elsewhere. So patient might be having lymphoma, and lymphoma can also present with things like this. This guy is young, chest pain. They can have nodes inside the chest, which can be painful. Weight loss, fever, chills is there. Probably diarrhea doesn't make much sense. But again, what are other causes of cervical lymphadenopathy or generalized lymphadenopathy apart from this cancer, which is a lymphoma? So infections are there, and some that I know, like any infection can cause lymphadenopathy, but to be generalized, you need some chronic infections. So TB can do that. Um, Secondary syphilis can do that. Yeah, without forgetting, if you see generalized lymphadenopathy, weight loss, should think of HIV. So this patient at the end should be tested for HIV. The other infections that I can think of, no, but okay, autoimmunities, they can also cause reactive lymphadenopathy anywhere in the body. Things like sarcoid, SLE, and other autoimmunity can also do that. So at this point, in a patient like this, yeah, I'm thinking of she's inflamed. What is inflaming them can be malignancy, lymphoma top there. It can be infection, chronic infections, TB, HIV should be considered. Autoimmunity, there is no much clues that we are dealing with an autoimmune disease here, but I will see later. So maybe David, and all these can explain now why this patient had chest pain 2 days ago, and but they started being sick some months ago. And I believe at the end of the day, when we image the chest of this patient, maybe we'll see some other lymph nodes sitting in there. Yeah, David, next.
Okay. Thank you, Joseph. So, can you give a brief summary so those who joined later can follow before we proceed?
Yeah, so David is presenting to me a case of a 29-year-old male who is presenting with 2 days history of chest pain. It is associated with fever, chills, and weight loss. This started 2 months ago. On exam of importance, they have cervical lymphadenopathy, and there is a history of diarrhea that I noticed.
Okay, thank you. So we proceed to the next aliquot. That's the past medical history. So the patient doesn't have any significant past medical history. The family history is positive for diabetes, hypertension, and heart disease. There is no significant past surgical history. So, on the sexual history, the patient is currently sexually active and has one male sexual partner. He reports testing positive and receiving treatment for syphilis about 2.5 years ago. Patient believes that he was also tested for HIV at that time and the results were negative. Okay, so that's the third aliquot. You can discuss that one before we proceed to the next one, which is physical exam.
Yeah. So one day we had a case here of a young person, and we say something very important that when a young person presents with serious disease, you should think of three things. Maybe they have think of behavior, bad luck, and bad genes. So bad genes, bad behavior, bad luck. Bad genes, they have these congenital diseases. Bad luck, it's just there. Someone 29-year-old, they have a very bad MI. It's just purely bad luck. And again, bad behaviors, you're talking about risky sexual behavior, drugs. So, like this patient has risky sexual behavior. MSM is very risky in terms of acquisition of HIV/AIDS. So yes, and one another thing, they had syphilis in the past. So STIs travel together. When someone is had syphilis, chances that they had another STI, they're very high. So these include things like gonorrhea, chlamydia, and of important in this case, HIV. Although they are tested previous and they're negative, it doesn't mean what is happening today. And this is very important. So at the end, I think this will be tested, and if turns out to be positive, it will change everything that we are going to think about in here. Yeah, I think only that in that aliquot. David, you're muted.
Joseph, so, yes, so Joseph, I have a short question before you proceed. This past history of being treated for syphilis, does it make you think about anything specific as far as the chest pain and the entire presentation of this patient is concerned?
Yeah, that's a very very good question. So, yes, in latent syphilis, uh, there is this. There are two complications of latent syphilis. One is I think it's aortitis. Yes, it's aortitis. And what is the other? So yeah, CNS syphilis can present at any stage. So I think yes, I can think of that. So in particular of chest pain, yeah, if they have aortitis, they can have aortic aneurysm. But that takes lots of time. I don't expect it to happen in 29-year-old. Like these are like 50-year-old, and they will tell you a previous history of being treated with syphilis. I think that makes sense.
Thank you very much for the observation. So we proceed to physical exam. So the blood pressure was 133 over 86. The pulse rate was 113. Respiratory rate 18 cycles per minute. The patient was starting 99% on room air, temperature was 37. On general exam, the patient was alert, in no acute distress. On exam of the skin, he had seborrheic dermatitis on the face, and he also had hyperpigmented patches over the chest and back. On a CVS exam, the patient has tachycardia, no murmurs, no peripheral edema. Respiratory exam, lungs were clear to auscultation bilaterally. On examination of the lymphatics, he had palpable cervical and inguinal lymph nodes. Musculoskeletal system, normal range of motion, normal strength, no tenderness, no swelling, no deformity. Per abdomen, the abdomen was soft, non-tender, non-distended, no organomegaly. Neuro exam, the patient was alert and oriented with no focal neurological deficits. That's the physical exam. Can you discuss that one now? The next one will be labs.
Okay. Yeah, so not much discussed there. The tachycardia, we've already seen it even before, and I can explain it that this patient is in pain, and then they're distressed. Like having a chest pain is not a simple thing. If I have it, I also have tachycardia, surely. But looking at the other vitals, they seem to be in a range, and they're not so much scary. Uh, so they had seborrhea. Seborrhea, I believe, will present in the central face and the scalp. I wonder if maybe I'm limited there, but I don't believe it's seborrhea present also on the chest. That you're saying they have patches on the front and back. So my approach to any dermatological lesion is to ask myself, is this disease coming from the inside of the body or outside? If I put a watch on my wrist and then I had a rash that is itchy, the watch caused that rash, and you say this is simple, you call it contact dermatitis, give me some topical steroid. But if something is distributed like this in front and back, we wonder if this thing is coming from outside, and we think it's coming from inside. In a patient like this who is losing weight, uh, risky sexual behavior, and inflamed, if something is coming from inside, I can think maybe they've. I've not seen the rash, but I can't think of anything specific right now with the patch. I don't know. Maybe I'll have to see later if you show me some pictures or what. But I cannot tell. But I believe whatever they have, these patches that they have on the front and back also is related to that particular disease, where maybe it will be a chronic infection at the end or an autoimmune disease. They all present with some rashes that even maybe sometimes we cannot explain them. Very importance is the generalized lymphadenopathy. Now it proves it is in the cervical and then it is in the linguinal. You said they are. Did you say whether they are tender or non-tender?
Let me see if that is mentioned. No, it's not mentioned. They are just palpable,
Yeah.
cervical and inguinal lymph nodes.
I assume they are non-tender. If they were, you should have been said. So yeah, I think I've discussed a bit about this. Either they are reactive to something, infection, autoimmunity, malignancy, or they're just popping out from the cells are being crazy, which is things like lymphoma. Um, so I think we'll proceed to the labs and see what we have.
Okay, so we go on with the labs. We start with the CBC. WBC count is 9.1. With segmented neutrophils 46%, lymphocytes 37%, monocytes 17%. On peripheral smear, there are few on the peripheral smear. There are few variant lymphocytes, rare smudge cells, slight anisocytosis, rare microcytes, HB 8.3 grams per deciliter, platelets 350. The complete metabolic panel, the comprehensive metabolic panel, sodium was 133 millimoles per deciliter, potassium 5, chloride 99, carbon dioxide 27 millimoles per liter, glucose 121 milligrams per deciliter, BUN 10 milligrams per deciliter, creatinine 1 milligram per deciliter, total bilirubin 0.6 milligrams per deciliter, AST 22 international units per mil, per liter, ALT 15, total protein 8.7, which is high, albumin 2.4, which is low, D-dimer 43.44, which is labeled as high, while troponin is less than 0.01. Yeah, so that is about labs. The next one will be on imaging.
Okay, so I didn't catch some things. I think your internet cut a bit. You said the HB was 8.3 and the MCV was
Okay, so there is no mention of all the indices. It's only HB that is mentioned. MCV, MCH, MCHC are not mentioned.
and the protein is how much? Total protein.
Total protein 8.7
Why the albumin?
is 2.4.
2.4. No. Okay. So in 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 the in the CBC, I catch that there was anemia. When you see anemia, you think is it the problem of production of the RBC, or is it production of peripheral destruction of the RBC, or is it loss from the body? Uh, in this patient, we and plus the lab that were done, we're not seeing anywhere that's suggestive for that he is distracting RBC peripherally. The bilirubin would have been in a certain way. Another is that there is no story that he is losing blood from anywhere. A young guy like this, most commonly, if he's losing blood, will be losing from through the GI. Would have seen the feces, for example. He has a Bractari, the Melena feces. So no loss, no peripheral destruction. How about production? Production, if production is impaired, less likely to impair only RBCs, less likely but possible, maybe in some very rare diagnosis, pure encephaloplasia, let's say. But we're not seeing, most commonly when we see peripheral lymphadenopathy and you think there is impaired production of RBC, there will be also a decline in other cell lines, 2 or 3, just we're seeing only one. So at the end of the day, if you work out your anemia and then you realize you don't have anything else, uh, you think it's anemia of chronic illness, but you should be very careful. Anemia of chronic illness is a diagnosis of exclusion. You have to do it. You have to say it's anemia of chronic illness unless you have done all other investigations and realize you don't see any other cause. And truly, the patient is inflamed. This patient is inflamed from the presentation you're just seeing. And yes, anemia of chronic illness, it is never moderate or severe. It is usually mild, like this one, 8.3. So moving on, we're seeing a hyponatremia of 133. I'm not going to discuss anything on that because that will waste our time. Most will not turn out into anything. uh, this guy maybe is not eating well, they're just a bit dehydrated, and when you do other labs, you find sodium is normal. Sodium, if it is moderate, severe, or if mild but recurrent mild hyponatremia, there you want to discuss about hyponatremia. So the protein at albumin is very interesting. In the body, we have total protein and we have other proteins now that make that total protein. And the major two types include albumin and globulin. So the albumin and globulin make most of these total protein. If you take the difference between protein and albumin, you get the globulins. It's usually less than 4. This one is 6.3. So it tells you the globulins are high in this patient. This patient has hyperglobulinemia. Hyperglobulinemia can be polyclonal or monoclonal. Polyclonal, it means multiple clones of the globulins from inflammation, maybe a chronic infection, a malignancy, or autoimmunity. But again, it can be a monoclonal one. A monoclonal is just a specific type of those globulin. They are replicating themselves. Think of multiple myeloma, for example. That's a monoclonal. How do you know? You send what is called an SPEP, as serum protein electrophoresis, which now will tell you whether there was an M spike in this monoclonal or polyclonal. This patient being inflamed like this, I think this will turn out to be a polyclonal hyperglobulinemia, because there is nothing that tells me this can turn out to be a monoclonal. Multiple myeloma is impossible in 20 something years old. Other monoclonal gammopathies will include amyloid. I didn't see anything suggestive of that here. And another one is Waldenstrom. Again, nothing that suggests of Waldenstrom here. Those three are the major ones. There are other very esoteric. I don't know about. I can't even think about them. I don't know them. A D dimer is also an inflammatory marker. So being raised in a patient with chest pain today, you would think it is taking you into trying to say, oh, is this a PE or something? You do your score and stuff. But again, less likely, because this guy has been inflamed 2 months and now chest pain is just today. But at the end of the day, I believe that it will be done. So a troponin of 0.01, if repeated after 30 minutes, again it's less than 0.01, rules out the possibility that the myocardium of this patient are crying of missing blood. And it says that among those serious diagnosis that we are thinking, which included ACS, they can't be possible in this patient. So at the end of the day, we remain that this patient is inflamed based on that a globin gap of more than 6, with a chronic, with anemia of chronic illness. What exactly is inflaming this patient? We need more labs. At this point, I would love to send an HIV before proceeding to anything else, by the way. Yeah, David.
Okay, so I was having a problem actually with my connectivity as you are discussing anemia. So if you can just repeat for me what you are discussing on the albumin as well as the total protein, just briefly before we proceed.
Yeah, so the approach of anemia taught in medical school, think of three things. Is it the patient losing blood? Are they not making enough blood? Or are they distracting blood peripherally? Meaning they are not making blood, maybe they're not the marrow is not making enough blood, or they are losing a guy like this. I say if they are losing blood, so will be the GI, but there is no such thing. There is no lab that is showing they're distracting blood peripherally. We're talking about hemolytic anemia. And so I tend to say maybe this turned out to be anemia of chronic illness, which is a diagnosis of exclusion, by the way. If you say that, you should put a question mark at the end. The the protein I said, so total protein is made by two major proteins, which include albumin and globulin. If you take total protein minus albumin, you get the globulin. It's usually below 4, the difference. But this patient is 6.3, which means they have hyperglobulinemia. So you will need to have an SPEP to say, is this a monoclonal or polyclonal? If it's monoclonal, there are diagnoses: multiple myeloma, amyloid, Waldenstrom. Polyclonal, these will be inflammations, chronic infections, autoimmunity malignancy. That was it.
Okay, thank you very much. So we proceed and we have some imaging. So on the ECG and chest X-ray were done. So ECG revealed sinus tachycardia, no ST or TOF changes. Chest X-ray, no acute infiltrate was identified. That the heart size is within normal limits. CT angio was also done. No evidence of pulmonary embolism, but there was bilateral mediastinal axillary as well as hilar lymphadenopathy. Can you discuss those before we proceed to the next reports?
Okay. Yeah. So as we saw it initially, the tachycardia is a sympathetic drive, pain, no fear. Turned out to be sinus tachy, no problem. Chest X-ray being normal. You know, chest X-ray is good for three things: pneumonia, um, pneumothorax, and pulmonary edema. Out of that, you should do a CT if you are assessing any other thing. So yes, these guys did a CTPA. There's no PE. Very nice, but we are told they have mediastinal lymphadenopathy. There is this mnemonic that if you have influence in the mediastinum, you think of the possible causes. You think of the four T's, and these include a thyroid, a thymoma, a terrible lymphoma, and lastly is the teratoma. Yeah. So at the end of the day, in a patient with a generalized lymphadenopathy, also, I'll put lymphoma up there more than anything else. Yes, there is also a fifth T. I read recently said that testicular tumor mets. Someone can have a testicular tumor met and they met in the mediastinum. So I have five T's nowadays. Yeah, so we proceed and see what are these. What among these will turn out to be one of these T's? But I think lymphoma is number one with a guy young like this. Um, yes, and another thing, they have risk sexual behavior. We shouldn't forget they haven't sent HIV. So if they send HIV, patients with HIV are more likely to get lymphoma as a cancer than the population. So still, lymphoma is up there, but I will still send HIV and see.
Okay, so uh, we'll proceed to the next aliquot. I believe we have 3 to go. So supplemental labs were done. HIV antibody antigen, so that is a combined one. It was positive. HIV-1 was positive, while HIV-2 antibody is non-reactive. So it's basically HIV-1. So yeah, that is, so we have two more records to go. So can you now discuss it in light of the HIV results that you are waiting for a long time?
Yeah, so now that will be easy because these patients have not only HIV, but they have also have AIDS. I believe they're not using medication. And they can be having AIDS defining presentation, maybe one of them. But because they have weight loss, they're inflamed, and they have other stuffs. So if they're having HIV AIDS, what is the disease now that is troubling them? Because HIV AIDS, this is just an umbrella. And as I said, patients with HIV more likely to get lymphoma than the rest of the population. So the next thing I think is to take one of the nodes and see whether there are lymphoma cells.
Okay, so we'll proceed. Um, Flow cytometry of peripheral blood was done. No immunophenotypic evidence of a lymphoproliferative disorder, leukemia, or myeloid disorder is identified, and no diagnostic immunophenotypic abnormalities which were detected.
That's a flow cytometry of the
Okay, so can you discuss that one?
uh,
Peripheral blood.
okay. Yeah, so no
Yeah.
lymphoproliferative disorder. Okay, that's tricky. And I'll still wait for the biopsy. I can't say on that.
Okay, so yeah, so that is the last tally quote. I'll comment on the core biopsy, and I believe after that one you will commit to a diagnosis, if any,
Sure.
before we reveal the final diagnosis. So core biopsy of right inguinal lymph node was done, and here we are the histopathologic findings. Atrophic germinal centers and strong preponderance of plasma cells, and special stains which were done included CD23, which demonstrated residual atretic germinal centers, BCL2 outlining atretic germinal centers, CD34 strong vascular background, CD128 numerous plasma cells, kappa light chain numerous plasma cells, lambda light chain numerous plasma cells, and HHV8, that is human herpes virus 8, was focally positive in spindle areas. So uh, that's the last tally quote. Now, if you can discuss that one and commit to a single diagnosis or a number of diagnoses, if any.
Okay. Um, yeah, so when I was saying lymphoma, I waited for the biopsy to turn out telling me Reed-Steinberg cells or non-Reed-Steinberg cells stuff, but turns out that biopsy screams that this is not a lymphoma. So in this juncture in diagnostic reasoning, you have to go back and draw again because you think it's lymphoma, but it is not. So what are the other things that can look like lymphoma, but they are not? That would be the question. Or put it in other words, what are the other possibilities of diffuse lymphadenopathy? So yes, I've said infections, but there is no clue whether we're dealing with an infection because there is no site that is infected. We would have seen maybe they have cough or stuff, but it is not. So I think it is not infections. The autoimmune disease that can present with generalized lymphadenopathy. I said, if you think of autoimmune disease, just think of S. There are many starters with S: sarcoid, SLE, Sjogren. Uh, there are other S's, I believe. And then there is no anything. Being a male also is protects you a bit against against autoimmunity. Drugs, I don't see there are no any other drugs. So we go back and say this has to be a malignancy, but it is not lymphoma leukemia. Those when I listen to those, it means they have been ruled out. And now what else? Lymphoma leukemia. I don't see any other cancers. Okay. Yeah. Now, if I have to guess now, I hear HHV8 whatever positive, right, David? HHV8.
Yes, that's right. HHV8 positive in the core biopsy.
Yeah, so for me, something else which looks like lymphoma, but it is not, and you're telling me about HHV8, I think, and the patient is HIV positive, I think of what is called a Castleman disease. Yeah, a Castleman disease. Um, this is driven by HHV8, the little knowledge that I have. And yes, it can be multicentric Castleman or unicentric Castleman. This will turn out to be multicentric Castleman, which occurs in HIV patients. And yeah, I believe that's it. And if they are treated HIV, it goes away. I think that HTV8 would be a clue to me if the pathologist saw that. I would say we're dealing with Castleman. I think I'm done.
Okay, Joseph, I'm not sure if you are still speaking.
Ah,
Okay, okay, and I just saw a comment from Noreen here. She's commenting. So, Joseph, as you are discussing, could this be what she's suggesting? What about Kaposi sarcoma? Is that a possibility?
yeah, yeah. So Kaposi presenting like this, I think not, because Kaposi we have lesions. This lesion can be on the skin or mucous membranes. So if they are not on the skin, which we can see them, maybe they're in the GI, maybe they're in the respiratory system. The respiratory system, patient will have respiratory symptoms. They have coughing up blood. When we put our scopes, we'll see them. In the GI, they'll be having a protracted chronic diarrhea with blood sometime. When we scope them, we would have seen it. But again, Kaposi, it can be there, but it is shouldn't necessarily cause the generalized lymphadenopathy to the extent of causing lymph nodes in the chest. So I think I would say, even if I say it's Kaposi, I don't see where I would take the biopsy and send it. Aha, okay, and I understand your question is because of the HHV8. Yes, this is it. But again, the presentation is not like Kaposi. Of course, HHV8 is you also think of Kaposi, but it's not the presentation of it. But I know HHV8 in patients with HIV, lymphadenopathy, it resembles lymphoma. Castleman is also a differential diagnosis. I don't know if it will turn out to be KS or what, but that's it, David.
Okay, so just to reiterate, what is your final diagnosis for this case?
Mine is Castleman.
Okay, so you're thinking of uh, which one did you say? Unicentric, multicentric?
I think it's
Just to be very specific.
for HIV is multicentric.
Okay. So thank you very much, and maybe later on you'll tell us what made you arrive to this diagnosis of Castleman disease. I believe it's a new diagnosis to many of us, but it's been quite a journey. I mean, this was a very tough case, at least for me. I believe a number of people here can agree with me. What started as chest pain, and later on we had so many twists and turns. Uh, a 3 month history actually of constitutional symptoms, lymphadenopathy, many labs, peripheral smear, which revealed some funny findings, and then immunohistochemistry, uh, lymphadenopathy in multiple areas on CT. So it's actually quite impressive, the final diagnosis that you made, that you came to, Joseph. So case resolution, this patient was diagnosed with HIV and HHV8 associated multicentric Castleman disease. So he was discharged home with follow-up to begin antiviral therapy, and was set up for outpatient rituximab for his multicentric Castleman disease. Yeah, so I'll read a few teaching points here, which are included in this case, and then afterwards, maybe because we are already at the finish line. If there will be any additions or any questions, then we'll hear those, and also reflections from Joseph. So, Kesterman disease pathophysiology. Kesterman disease is a lymphoproliferative disorder that can present with unicentric or multicentric regions of lymph node enlargement. And multicentric Kesterman disease is subclassified into HHV8 associated, uh, multicentric Kesterman disease, and HHV8 negative, or what is also called idiopathic multicentric Kesterman disease. And half of multicentric Kesterman disease cases are found to be caused by HHV8, which is also known as Kaposi-sarcoma-associated herpes simplex virus. Uh, so in patients with HIV, about 50% of these cases of MCD are found to be caused by HHV8. And also so in HIV patients, but also in other immunocompromised patients. And the treatment of idiopathic multicentric Kesterman disease is different and challenging, and outcomes are often worse. But in those with HHV8 associated multicentric Kesterman disease, the plasma levels of HHV8 DNA further correlate with clinical symptoms and can be used to predict relapse rates in HIV-associated MCD. So on clinical presentation, patients with HIV-associated MCD usually present with systemic inflammatory symptoms such as fevers, night sweats, weight loss, and fatigue. And the system inflammatory symptoms occur, which promotes the production of acute phase reactant proteins and therefore resultant systemic symptoms. And also, an increase in the level of interleukin 6 also contributes to the laboratory abnormalities seen in these patients, such as anemia. Now we have an explanation for the anemia. Elevated inflammatory markers, the hypergammaglobulinemia that Joseph discussed, as well as hypoalbuminemia. Kaposi sarcoma or primary effusion lymphoma, which can also be HHV8 associated. Uh, and on diagnosis, there are no established formal diagnostic criteria for this form of multicentric Kesterman disease. But typically it is made when the following are present: when there is peripheral lymphadenopathy, constitutional symptoms, elevated inflammatory markers, and plasmablastic histopathologic findings, like we saw in this patient, and then HHV8 detection. Yes, so that is what is included in these teaching points. Now, Joseph, it's time now for reflections from you, and then we'll welcome the audience if there is anything from their side.
Yeah, so I thought it will end up to be a lymphoma, but again, a lymphoma, when the biopsy is read, you just listen for something. They don't tell you about Reed Steinberg cells of Hodgkin. They'll tell you about lymphoid pathologic cells that look the same, but it turns out it was not lymphoma. So you have to find something else. So Castoman, I don't know if I rotated with you in hematology, but when we was in the resident study, there was a group that was rotating, and there was a patient with Castoman in that hematology, and we talked with them, and they would tell us stuff. They wanted to present the patient in Grand Round. I don't know why they didn't, but for that, it was the story was it was also thought as lymphoma, sent the biopsy, and it was the biopsy guys who turned back and said this is Castoman. So it was not the clinicians. So even what I did is until when you told me in the biopsy, and it wasn't lymphoma, leukemia, and then it has to be something else. But yes, HHV8 brought a clue. Yeah.
Okay, so very impressive, actually. I mean, these are rare diagnosis, and like I said the other time, I think that was last week when we had a case of maternal inherited diabetes and deafness. Uh, the aim basically, and I think for us clinicians, I think we should avoid the temptation of chasing zebras, but then we need to be aware that even what we call rare diagnosis can actually happen in patients. And therefore, when a patient has a typical presentation of a rare diagnosis, you should not discuss it just based on grounds that this is very rare and therefore not likely to be plausible in this patient. Yeah, so the aim is actually not to start diagnosing every single patient we see with rare diagnosis, but then I think to improve our clinical reasoning, our background knowledge of different clinical cases, whether common or rare, in order to be able to diagnose them when we need to do that. So this was impressive, and I should say it was impressive starting with the entire journey, because I think we learned a lot of things from your approaching chest pain, approaching tachycardia, approaching anemia, approaching inflammation, approaching a skin lesion, uh, the differentials to think about in a patient who has mediastinal lymphadenopathy or a mediastinal mass. So I think there was quite a ton of things to learn from your discussion today. And then again, very impressive, because we always say it's about the journey and not the destination. But then you reach the destination with 100% accuracy. So with the rare diagnosis like this one, I think that was quite impressive. So I think Castleman disease is a new diagnosis, at least to many of us. So I think we'll leave this session today with an assignment to go and at least familiarize ourselves with this, and consider it in patients that we see next time. Because as I was reading the teaching points, it is stated that if you have a patient with lymphadenopathy, constitutional symptoms, and elevated inflammatory markers, so let's say CRP, ESR, you should consider Castleman disease. So I think maybe our reflex would be to consider things like lymphomas, Joseph said earlier, and some other common conditions like tuberculosis, which can present with, for example, TB adenitis. But then at the back of our mind, we should also have this as a differential, Castleman disease. So thank you very much, Joseph, for educating us today. Now, maybe let's just take a few minutes. I saw a number of hands previously. So if there is anyone with a question, a comment before we round up the session, you are very welcome. I saw some hands initially. If anyone has any question, any comment, or anything that you'd like to share, anything that you'd like to say, if you'd like to congratulate Joseph for getting a rare diagnosis right, anything, you're welcome before we close the session.
I think the hands were raised accidentally.
Yeah,
Clara is here. I believe when I was in third year, Clara had the patient with cancer. Clara, am I right?
Hello, Jose. Hi, David.
Hello.
Hello, Clara.
Yeah, thank you so much for the presentation. I guess it was really nice. Initially, I loved Joseph's approach and everything. I don't remember having a patient with Castleman disease. I don't know. I don't remember. Maybe it was Irene,
Was Iron,
if
yeah?
I'm not mistaken. Yeah.
Okay, yes.
But then again, it was a really nice approach. Initially, I remember the last case we presented on pulmonary embolism, patient with syncope. So when you are presenting, I thought of chest pain, and telling us that the patient had awareness of heartbeat and had an episode of syncope. I thought of pulmonary embolism initially, but then things started changing as you continued with other alipods. So I think it was a nice case. Thank you so much.
Thank you.
Good learning points today. Yeah.
Thank you very much, Clara. So, yeah, I think we've added a number of things in our knowledge bank. Joseph's approach to all these different clinical problems, and then uh, to ice everything with the diagnosis of Castleman disease, which I think we're going to explore. Before we close, I should make the same call that we make a number of times. We do not mean to monopolize presenting and discussing, me and Joseph. We are very eagerly waiting for other people to join, either presenting or discussing the cases. So, and the cases don't have to be very complicated. I mean, you've seen us discuss cases of pulmonary embolism, cases of drug reactions, hyperuricemia. So, uh, a case that will help us learning either in approaching the diagnosis or even in management of that case. So, or a case that is incomplete and you want to get thoughts on how to make progress on that case. We welcome all sorts of cases. So, presenters, but again, discussants. We will be very happy to have someone volunteer to discuss and teach us the approach, because I mean, as much as I learn new things from Joseph and maybe Joseph learns new things from me, but you see now we have a lot of uniformity, for example, in the way we approach fever, in the way we approach inflammation. We use the same mnemonics, the same approaches. So I think it's about time we learn from other experts. So I would be very happy to have someone else present a case or discuss a case. And then on top of that, we would also like to get suggestions from you on any other things that you like us, for example, changes in the way we conduct the sessions, or any additional things that you like us to be discussing or doing. So if you have any suggestions, any comments, you can reach out to me through my email. So if you click on the profile there, you can get my email or Joseph's email and reach out to us if you have any suggestions. So if there is nothing else, I would like to thank everyone who stuck around for the past 1 hour and 15 minutes. That tells a lot about your commitment to learning. So we are very much happy to have you around, and we are hoping to see you back next weekend. So have a good night, everyone. Let's keep learning and let's meet next weekend.
Good night.